prevented. Now this shows the long-acting beta-2 time course, and we have heard of methacholine challenge test. And this is a methacholine challenge test. This is the PC20. And once you give the, I'm sorry, I'm hurrying up a bit. Once you give the budesonide formoterol preparation, then you see it's a steep rise because of the formoterol bit, okay? And you see the time in minutes. It goes within a few minutes. If you use the formoterol, the same thing happens, but it happens a bit slowly. Whereas the placebo hasn't worked. So we know that formoterol is very quick-acting drug. Now this we ill understand this thing, the molecular mechanism of asthma exacerbation. What happens? This is the epithelial cells, and we know that most of the asthma exacerbation is through this, and it is possibly rhinovirus. What they do, they come to the epithelium, and so does the pollutant. Whereas the allergen, they directly stimulate the mast cells, and we will come to that again. What they do, they stimulate the epithelial cells, which in turn excites the mast cells to liberate all these cytokines. They are the inflammatory cytokines by which the bronchoconstriction starts and the plasma leakage starts, giving you the inflammation and exacerbation. What happens if you give formoterol? What formoterol does, it comes and blocks this. And so this cannot, and I will come to that again, cannot excite the mast cells. It definitely bronchodilates, and it also has effect on plasma leakage. Now this is a study, and this is a study we all know, and I have cut down a few slides, and I will come to that later if you ask me any question. These are the sputum eosinophils, and sputum eosinophil is a surrogate marker for your asthma value. So if they have done a sputum eosinophil, and they have given some budesonide, okay? Sputum eosinophils here and budesonide there. So you see that the sputum eosinophil has come down, and so budesonide, and see that the time course, it's within 6 hours, but it's a very large dose of inhaled corticosteroid, budesonide. And if you see, the bronchial reactivity has also lessened in that time. So budesonide is always, we think that the steroid is very short, takes a very long time, and that's true when we measure the lung function per se. But when we measure the lung inflammation, it starts working pretty quick. Now it is the same sort of study, but do you get cyclosinide here? No. The cyclosinide is a soft steroid, and it is good steroid. However, it is pretty expensive. What that's shown is this is the adenosine bronchial challenge, because instead of giving methacholine, you can give adenosine for bronchoprovocation. And if you do that, you see that the PC20 it goes up, so the bronchial hyperresponsiveness comes down, and this comes down within 3 hours. And 400 micrograms is not a very, very big dose. So it comes down within 3 hours, but what is most surprising is that it stays at that level even at day 7. So it goes up, the bronchial hyperresponsiveness comes down very quickly in about 3 hours, and it stays like that for more than 7 days. So we know that adenosine monophosphate actually causes bronchoconstriction through mast cells, and that's why we infer that the cyclosinide, the steroid, possibly inhibits the mast cell from liberating the cytokines. And we will show you another diagram. This is the diagram. So this is the epithelial cells, and these are the mast cells. And the mast cells in asthmatic airway, they line the epithelium, and they can only line the epithelium with the help of this stem cell factor. That's another cytokine, because they have it in asthmatic airways. What happens? They stimulate the cold air, the temperature variance. What they do, they stimulate the epithelium, and immediately these mast cells get stimulated to liberate all these cytokines. What steroid does, the moment the steroid comes here, it blocks the stem cell factor. The moment the stem cell factors get inhibited, the mast cells cannot stay there. So the mast cells disappear, and so the bronchoconstriction comes down, because the inflammation starts coming down. this is, I'm trying to prove that the formoterol is a rapid-acting, and so is the steroid, contrary to what we always believed. They did a sputum cytokine in asthmatic patient. What they did is they measured the IL-6, and there is another cytokine called MIP-1 alpha. And you see, with both the small dose and the big dose of cyclosinide, that's another steroid, it comes down pretty quick, in 3 hours. Now, this is an important slide. This is the Th2 lymphocyte, and we all know that Th2 lymphocyte is the cell which causes all these problems. It increases IgE, it recruits all these inflammatory cytokines, liberates them, and it is activated through the antigen-presenting cell through these cells. However, the Th2 lymphocyte can only do this when they stimulate one transcription factor called GATA3. When the GATA3 is activated, all these starts happening. So we can safely say that the relationship between the environment and production of asthmatic inflammation lies between this molecule, the transcription factor of GATA3. This is apparently the most important factor in causing the asthmatic inflammation. Now, the GATA3, am I getting too complicated? GATA3 lives in cytoplasm, GATA3. However, this cannot do anything unless it's phosphorylated. And the phosphorylation is done through the activation of the antigen-presenting cell through the help of this enzyme. This enzyme is activated by the antigen-presenting cell, it's p38 MAP kinase, which phosphorylates the GATA3. Now, the moment the GATA3 is phosphorylated, it has to come to the nucleus, because unless it comes to the nucleus, it cannot activate the gene. The genes are all in the nucleus. So the moment it is phosphorylated, it comes down into the nucleus. How? There is a channel there. There is a channel, it comes through this channel, and then it selects out this inflammatory gene, which liberates the cytokine, which starts liberating the cytokine, and we have an allergy, inflammation. Okay? Now, what does the steroid do? The glucocorticoid receptor are in the cytoplasm too. It is not in the nucleus. So the moment we give glucocorticoid, it comes through into the cytoplasm and activates it gets attached to the glucocorticoid receptor. The moment it happens, the glucocorticoid receptor comes into the nucleus. There is no protein synthesis, nothing. So this is very quick. So what it does, it has come in. But the beauty of this coming in is that they use the same channel, the same path. When I came from the airport to here, it took us, 1.5 hours, sort of. It's a real big traffic jam. And when you give corticosteroids, the same thing happens here. That's a big traffic jam there. But because these glucocorticoid receptor are VIPs, they have this blue or red light on their car, they get preference. So they don't allow the GATA3 to come in. So the GATA3 is inhibited. The moment it comes in, this production of interleukins are stopped, and the allergic inflammation starts coming down. However, this is not all. This is very quick. The steroid has got another function. It comes down and activates this gene. It's called NKP1 gene. And this gene liberates